Mr. Chairman, thank you very much, and thank you to Professor McGurk for inviting me to give this presentation. He was keen that we reviewed the history, because as we know, surgery, nothing's new in surgery, and hopefully I'll show you some of that during this presentation. So, and we'll talk a little bit about a new classification, but I'm acutely aware of the time for lunch, and no one's popular if they keep people waiting for lunch, so we'll get on. These are the Lamquire painting, or one of the Lamquire paintings. They were commissioned by a chap called Peter Parker, who was a Yale surgeon. He went to China in the mid-19th century, and there were 115 paintings like this in all, some of which now, 86 or so, 90 or so remain at Yale. Some of them have come to Guy's and are in the Gordon Museum. And this is a 41-year-old shoemaker called Wu Pun, who had a cartilaginous tumour that had been there for 14 years, 17 years or so. And the local Chinese medicine men would stick escharotics in it, presumably, to try and get rid of it. And he had a stopper, literally a cork in it, and would take it out every day and drain something out of it. But it was removed, and the operation took a few minutes, and he didn't murmur a word, is what it says in the report. And I'll come back to that a little bit later on, because people always compliment their patients on how they don't fuss when the operation's done with a local anaesthetic. It's another example of the Lamquire paintings. This is John Barley. This is the first real report of a parotid tumour operated on in this country, and it's John Hunter, a very famous surgeon, as we know, his patient. And the operation was performed in 1785. It took 25 minutes, and again, the man didn't cry out during the whole procedure. Remarkable result, as you can see there. It's maybe a bit of artistic license, but his symptoms after the operation were mild and gentle, and he recovered rapidly after that under local anaesthetic or whatever anaesthetic they had, but certainly not a general anaesthetic. Very pertinent to Dublin is a surgeon called Richard Carmichael, who made an account of extirpation of a tumour of the neck, which was a parotid tumour. This comes from 1821. Richard Carmichael was president of this college 3 times, 1813, 26 and 1845. After he'd been got rid of the first time, he presented a tattooed Maori head, which I believe is upstairs in the museum here. And funnily enough, he was then made president again. This was some sort of threat, I believe, to... but anyway, he set up the Lock Hospital here, and then the Hospital of Industry, House of Industry, and was a co-founder of the Richmond Hospital and School of Surgery in Dublin. Published it in the King's and Queen's College of Physicians transactions. And this is a painting, obviously keeping the patient's confidentiality maintained, and this had to be done by the house surgeon the day before the operation. So times have changed. Fortunately, we're not commissioned to paint our consultants' patients, or not anymore the house surgeon, but clearly a large tumour. And the surgeon makes an account of this, and he says that he prepared to compress the carotid trunk before dividing the band that kept this tumour in at the time, but unfortunately, when he used an instrument called a buttoned bistoury, which is this thing, not used in surgery anymore, he got a rush of blood. He then removed the tumour itself, but noted that he tore off the facial nerve from the base of the skull as he did it, and he says here, right at the bottom, which afterwards found to cause paralysis of the side of the face. Again, he said the patient didn't utter a murmur, and he walks from the table unaided, as you can see there, declining every kind of assistance which the pupils were anxious to present him. Now, he was probably a leader in his time for medical education. And first of all, in assessing the operation, he looked at went well, so the success of the operation shows the possibility of extirpating the parotid gland. Then he says what went badly. However, if I should be called on again to perform this operation, I would in the first instance pass a ligature around the carotid trunk. Then he rather ruins it, because then he finds someone to blame about this. So, if in doubt, blame your assistants. And he says, this previous step, which had been in my intention in the previous instance, but from which I was dissuaded by some of my judicious and experienced assistants. So, he finds someone else to blame for the fact that they bled everywhere. And actually, one of those assistants was Abraham Colles. Moving on a little bit, 1832, American paper by a chap called Mott, and this was a very hard tumour and was actually found to be a melanotic condition. The operation lasted an hour, and the wound healed within 2 weeks, but unfortunately the patient died of multiple skin lesions on the wound and the scalp. So that was probably a melanomatous deposit. Then we move on to the first account that I can find of preservation of the facial nerve. And this was published in the Lancet in 1907 by Carradine, who was a general surgeon in Bristol. This is his only paper in the Lancet, yet he published in many different journals. That's him, I know that, because it had a legend underneath it. But this is the paper, very short and to the point, as you can see, just one column width, and it was an 18-year-old female patient with a recurrent mixed parotid tumour. And at 1 year, he says there was very little inequality in the movements of the two sides of the face afterwards. So he describes this as by patient dissection with a small, sharp scalpel, the nerve was successfully freed and held up in a loop of catgut while the whole gland was excised. So that's the first account that I can find of saving the facial nerve during removal of a parotid tumour. Then there's this book. Now, this chap, Blair, we know of the modified Blair incision, published this book, his Surgery and Diseases of the Mouth and Jaws, in 1912, and the second edition came out the very next year. And then subsequent editions very quickly after that, especially with the progress that was made during the war. He was a professor of surgery in Washington. Now, when you look at this book, and you can get this book now because it's out of copyright, you'll see that he was way ahead of his time, or certainly described operations that were described much later. Two pictures there, the top one of what is the Bramley-Al-Khayat described incision, and he accurately describes how you should go down and how you should take the fascial layers to protect the temporal branch of the facial nerve when approaching the TMJ. Similarly, the lower picture, that's him showing how when you're taking out a thyroglossal cyst that runs behind the hyoid bone, you should take out a section of the hyoid bone, Sistrunck's manoeuvre, which wasn't described by Sistrunk for another 10 years. That's his incision. That's the Blair incision. Doesn't look anything like the Blair incision we use. And interestingly, he having described how to keep the facial nerve with the hockey stick incision, he comes right across the middle of the zygoma with that incision, which presumably would compromise the facial nerve. And actually, the incision he made, this was to lay open parotid abscesses. That's him describing his incision. I won't dwell on that. But he here says that you should remove the capsule. If the tumour is surrounded by a capsule, it's not necessary to remove the gland unless it is so nodular that there is doubt of including all of its prolongations. So exactly what we've been hearing already. With all but malignant tumours of the parotid gland, the seventh nerve should be preserved, which complicates the operation. Now, even with very large tumours that are still encapsulated, it shouldn't be sacrificed, and I won't dwell on that bit, really. But the one thing he does say here, and this may be the first description, or it's not very accurate, is that it's advised to locate the trunk of the nerve as it emerges from under the upper part of the anterior belly of digastric. Now, did he mean the posterior belly of digastric? And then follow its main branches. So perhaps he's describing finding the nerve trunk there, which hasn't been done before. Now, Sistrunk. Now, this is the first edition of the Surgical Clinics of North America, this is the Mayo Clinic. Sistrunk had 4 papers in this, 1921. And there you can see his Sistrunk's procedure as it comes in that. And there you can see a very similar picture of what Blair published some years before. Now, he talks about that the capsule is thin and easy to rupture, and the capsule must be removed and distended with gauze, and he uses a solution of bichloride of mercury and hydrochloric acid. If the capsule is ruptured, he packs the cavity with that and then removes, as we saw earlier in the previous lecture, taking out the capsule having enucleated the contents. But he's not suggesting that. That's what he says if it ruptures. He describes now finding the inframandibular, as he calls it, marginal mandibular branch of the facial nerve and tracing it backwards. So he is the first that I could find describing a retrograde approach to locating the facial nerve. Doesn't talk particularly about finding the trunk, and he puts his finger up behind the gland to protect the pes of the nerve. First person to publish any results, really, and here he says that for a primary procedure, his recurrence rate, and this is only over a period of 6 years, was 18.3%, compared with recurrent disease, his recurrence of 38%. So we've got temporary paralysis of 24%, but permanent hemifacial paralysis for a primary procedure down as low as 1.5%, which is similar to what we're getting now. Temporary being less than 1 year. Adson, neurosurgeon, colleague of Sistrunk, worked at the Mayo as well. And he modified this, and all you'll see there is that the incision comes a little bit further up in front of the ear rather than just going behind the ear. And that's his modification of Sistrunk's description of the surgical procedure. Now, just very quickly on the recurrence, because recurrence was the big thing at this stage, with most people enucleating the tumours. 15.5% of tumours recurred within 5 years, according to Kennan from Liverpool, due to liberation of the capsule split, and he recommended excision rather than enucleation. Now, Benedict and Meigs, Americans who looked at 2 hospitals, relatively small number, their recurrence rate was 30%. This is what's quoted later on for the reason for doing superficial parotidectomy. McFarland travelled around 27 different hospitals on a horse, looking at 90 surgeons' different work. And he says here that in the microscope, beyond showing that the lesion is a mixed tumour, is misleading rather than enlightening. And interestingly as well, he points out that smaller tumours are more apt to have a small undiscovered outlying lobules that are left behind at operation, making it more difficult. Going to 1939, Hook reviewed all the literature up to that stage and essentially said the same sort of thing. Radical operation causes facial nerve paralysis, while incomplete excision fails to cure the disease. Intracapsular enucleation is inefficient, extracapsular enucleation widely practiced. And he recognized the features that would delineate malignant from benign disease. So fixation of the tumor to the skin or deeper structures was the most important one, and then subjective symptoms less so, faster rate of growth, facial paralysis, and the hardness of the tumor. The radiation was used at this stage, particularly in Stockholm. This was to become the Karolinska Institute, but it was an 8-bedroom apartment above a shop where they irradiated people. And the surgeon was a chap called Hibinet, worked with this man, Ablom. And they said that practically all cases should be treated with radiation. They would enucleate the tumour first and then irradiate it, sometimes placing radium rods within the tumour itself. Their recurrence rate was 1 in 25. Now we move on to Hamilton Bailey's paper. And so Hamilton Bailey, famous surgeon, famous book. He wrote in 1941 in the British Journal of Surgery, slightly different from Adson and Ott, but still not describing finding the trunk of the nerve, as perhaps Blair did earlier. And that picture there shows that what he did was he tried to find the inframandibular branch, the marginal mandibular, but couldn't manage it, he said, and he would work from top to bottom of the gland, lifting the gland until he found the facial nerve. And he did say that the upper border of the digastric muscle can be used as a guide for finding the main trunk of the facial nerve, but he certainly worked in a retrograde direction. He then published another paper in 1947, and he was keen to, as he says, dispel deep-rooted beliefs concerning parotid tumours that amount to old wives' tales. He talks about the bogey of facial paralysis. He's quite a verbose and eloquent man, but does go on a bit. So the bogey of facial palsy, pernicious practice of waiting for the tumour to get larger, which is what people did before. They were very worried about facial palsy, so they waited and then took the tumour out when it was large. The illusion of enucleation doesn't work, and that radiation, he said that nearly all parotid tumours are completely radio-resistant. He was a man for very dogmatic statements. Now, this is the picture that he has in the paper, which shows him ligating the carotid trunk, as he said, the external carotid. And he describes finding the temporofacial division in this paper. And this is a technique of extracapsular enucleation that he does, or extracapsular dissection, and he makes the point that you need to take a cuff of normal tissue around the tumour. So this was going on a long time before the recent debate. Hayes Martin, another famous surgeon, 1952, 2 cardinal principles of parotid surgery. Firstly, complete removal of the growth and avoidance of injury to the nerve. Now, what he said was that, and this was the same with Leahy and the thyroid, is that it's important it is only by exposure and identification of important structures that injury to them can be avoided with certainty. And so he was very keen on exposing the nerve. And he talks about ligating the external carotid as well. And then first real account of finding the nerve trunk using the mastoid process as the marker to find the nerve. And you can see the pictures there And then, of course, he invents some specially designed retractors he says you have to use. But this is the first real picture that I could find of the nerve trunk being found, and we're talking early 1950s now. Byers, preservation of the facial nerve, and he said, no effort is made to enucleate the tumour at the level of the false capsule where feasible. A thin layer of normal gland is excised with the tumour. An adequate or appropriate description of extracapsular dissection. He again finds the nerve using the marginal mandibular branch. And he makes the point here that at those points where the nerve fibres are closely applied to the tumour, the dissection is on the nerve rather than on the tumour, pointing out the bare area that is produced in that method. So Janes, famous surgeon from Canada, cardiothoracic surgeon, he became president of their association, and he, despite the fact he was a cardiothoracic surgeon, when he was asked to deliver the Moynihan lecture, talked about tumours of the parotid. He slightly changed the incision, noting that the Y of the incision where it goes behind the ear of the modified Blair's incision should be at an obtuse angle to avoid sloughing. And he talks about 33 cases that he did at that stage, and his results, and how he got to accessory nerve tumours. Now, what he said was, in the majority of instances, the pathological diagnosis of cancer comes as a surprise to the surgeon. So every case should be operated on as if they are presently or potentially malignant. So he thought that the people he worked with, that the primary benign removal of the tumour with an intact capsule and a few millimetres of surrounding normal tissue is adequate. That was his opinion. Where the tumour lies is in intimate contact with the fibres of the facial nerve, it's impossible to preserve that rim of tissue. And in circumstances such as these, superficial parotidectomy will accomplish no more unless part of the nerve is sacrificed. 1957. Then this is the confounding paper that really is why we moved to doing superficial parotidectomy. So Patey was a surgeon of the pectoralis major sparing mastectomy, and Thackeray was a pathologist. Now, Patey was awarded the Jacksonian Prize in 1930 for his paper on parotid tumours, and he set up the Cancer Research Campaign Salivary Gland Panel in 1965. He had a significant interest in it. But he says that tumours not only grow by simple uniform expansion, but by localised infiltration through the capsule. So this is the theory of sort of nubbles of tumour coming out. And a prominent feature of most mixed tumours is their nodular outline, and sometimes you can't see where the tumour joins the adjoining tissue. In an appreciable minority of cases, enucleation, which is actually, he's talking about extracapsular dissection, leave behind marginal areas of tumour tissue. And there's a special danger of implantation he talks of. And makes this statement, which is probably why we adopted the superficial parotidectomy, and that the only type of operation for primary mixed tumours of the parotid which will be pathologically sound in all cases is wide excision, i.e. some type of parotidectomy. Now there's a capsule of a pleomorphic adenoma showing the thin nature of the capsule, perhaps compressed parotid tissue around it, and in some cases virtually none. Now, previously this was discussed in the last lecture about Donovan and Connolly, who then challenged the notion that you needed to do a superficial parotidectomy, and they found in 40% of specimens only a thin rim of fibrous tissue separates the tumour from the resection margin, even in superficial parotidectomy. This is the bare area. In 21% of tumours, even in superficial parotidectomy, tumour extends to the edge of the specimen, and they said you don't need to do a superficial parotidectomy, it gives you no more. This is the paper, Gosch's paper that was highlighted before, just a little bit more information on that, 83 cases. And they found that the recurrence rate, and this is a 12.5-year mean follow-up, so it's a good follow-up, this paper, 17.5% recurrence if tumours cells at the margin of resection. So in other words, if there's a positive margin. But if they're less than 1 millimetre from the margin, but not at the margin, in other words, if there's any sort of capsule between your resection margin and the tumour, the recurrence rate is 1.8%. This was mimicked in a paper by Witt, who you've seen other papers from him today, Capsular rupture does not result in a significantly higher rate of recurrence and did not vary amongst surgical approaches between extracapsular dissection, superficial parotidectomy, and total parotidectomy with an 8 to 9 year mean follow-up. This confirms the fact that around between 35 and 40% of tumours have bare areas. And the relationship of intraoperative rupture and pleomorphic adenoma to recurrence was looked at by NatVig as well. And they found that capsular rupture occurred in 11%, with 8% getting recurrences, 8% of that 11%, so 26 out of 238. When the capsule was visualized, then recurrence rate was 1.1%, capsule not visualized, 2.5%. Oh, sorry, and the one thing, no difference in recurrence between microscopically positive or negative margins in pleomorphic adenomas. So Hamilton-Bailey summarised this by saying, as an experienced teacher, I am convinced that in the whole realm of clinical surgery, there's not a condition that approaches mixed parotid tumours for misconceptions. And I'll leave you to read the rest of that if you want. But the lovely bit he says at the end is, worse still, while it's still yet small and unencapsulated, previously locked up by nature, cells are let loose by surgical interference. So that's really the summary of the history of parotid gland surgery, and we're a couple of minutes late, and I apologise, but we're just very quickly on classification. And Prof. McGurk and I talked about this, and he was keen to try and bring the language together, because you've heard this described as superficial parotidectomy or lateral parotidectomy, partial superficial parotidectomy. But really what it boils down to is, do you dissect to find the nerve trunk? And parotidectomy classically is a nerve trunk dissection operation. So if there's no nerve dissection, this was either a nucleation, which we've ruled out, or extracapsular dissection, where you can achieve direct closure of the fascia. That has the benefit, direct closure of the fascia, of reducing Frey's syndrome and reducing any cosmetic deformity. If you dissect the nerve out, that can be divided into a partial superficial parotidectomy, and really, perhaps that's where you're just dissecting the trunk out and less than 2 branches of the facial nerve, and you can still directly close the parotid fascia. Again, Frey's syndrome, contour defects are important. A subtotal partial parotidectomy, you're not taking the whole parotid, you're taking a significant chunk of it, and you're looking at more than 2 branches, and in that stage, you will not be able to directly close the fascia. And then the classic superficial or lateral parotidectomy, selected deep lobe, and total parotidectomy, be that radical or nerve sparing. Mr. Chairman, that concludes the presentation. Thank you very much indeed.
Thank you very much, James, and thank you very much for taking us through the history, which is always very interesting. If you want to know where you're going, as somebody said, you have to look at the past. James, those pictures you showed me of extracapsular dissection, every one of them showed the parotid facial nerve dissected out. So I would contend that they're not really extracapsular dissections. What you showed there, and you said these people were doing extracapsular dissections. If you're doing an extracapsular dissection, you shouldn't see the nerve unless when you've done it under the microscope and you lift out the tumour with the dissection, there's the nerve underneath it.
Well, I mean, I think that the differentiation is you're not deliberately looking for the nerve in extracapsular dissection, but you will see it from sometimes. What they're saying is, what I'm trying to say is that they were not deliberately finding the nerve, but we're also saying that it was a safe procedure to take a rim of tissue around it.
I don't agree. Any questions? Because it's a very controversial area, and I know that there are some advocates, huge advocates, and I have to say I probably would myself. Any questions for James? You all want your lunch. Listen, thank you very much to everybody. The speakers were all fantastic today. I certainly have learned a lot, and I'd like to thank them as the way we normally do. Thank you all very much.